Good day, everyone. As part of the Endocrinology lecture series, I will be discussing the adrenal glands, its different parts, the hormones it produces, and their functions in the body. The adrenal gland has a pyramid-like shape located above the kidneys. It is composed of distinct but conjoined glands, the outer adrenal cortex and the inner adrenal medulla. The adrenal cortex is the outer region of the adrenal gland secreting the steroid hormone, and it is the major site of steroid hormone production. The adrenal cortex, in turn, has three layers. The outermost layer is what we call zona glomerulosa, which comprises 10% of the entire cortex. This is the principal source of mineralocorticoids, particularly aldosterone. The middlemost layer, which comprises 75% of the entire cortex, is the zona fasciculata. This is the site of glucocorticoid synthesis, and this also synthesizes dihydroxyepiandrosterone. Comprising 10% of the adrenal is the innermost layer of the cortex we call zona reticularis. So it produces androstenedione and dihydroepiandrosterone, which are actually weak androgens. So for easier memorization, the layers of the adrenal cortex are GFR, G for glomerulosa, F for fasciculata, R for reticularis. And the hormones they produce are MGS or make good sex, M for mineralocorticoid, G for glucocorticoids, S for sex hormones. The adrenal medulla, on the other hand, is responsible for production of this what we call catecholamines. These catecholamines are epinephrine and norepinephrine. So we will discuss these hormones one by one in the next slides. But let's start first with the adrenal cortex. Okay, so let's discuss first the adrenal cortex. So I've mentioned already that the adrenal cortex, takes part in steroidogenesis, producing glucocorticoids, particularly cortisol, mineralocorticoid, particularly aldosterone, and androgen precursors, DHEA, or dihydroepiandrosterone, and androstenedione, which are actually precursors for your sex hormones. So it has three distinct functional and histological zones, the glomerulosa, fasciculata, and reticularis, wherein the glomerulosa is the region where your mineralocorticoid is synthesized, the aldosterone. The fasciculata is the region where your glucocorticoid is synthesized, and the reticularis is the region where your androgen precursors are synthesized. So each layer produces steroid hormones from the precursor cholesterol. Okay? So a parent molecule of these steroid hormones is a cholesterol molecule. However, the specific steroid hormone produced differs in each layer because of zonal specific enzymes. All right. Depending on the enzymes which act upon this steroid precursor molecule, okay, so the enzyme would actually matter, no, on which particular area or zone of your adrenal cortex, because depending on the enzyme, it will actually produce a different steroid hormone, a particular steroid hormone. So let's discuss now the synthesis of these hormones. So once cholesterol, I want to direct your attention to the parent molecule cholesterol. So once it enters the cell, this what we call steroidogenic acute regulatory protein or the star protein, S for steroidogenic, A for acute, R for regulatory. So, STAR. The star protein regulates cholesterol transport from the outer mitochondrial membrane to the inner mitochondrial membrane. So the star protein transports the parent molecule cholesterol from the outer to the inner mitochondrial membrane. In the inner mitochondrial membrane, the cholesterol can be converted into pregnenolone, okay, via the action of the enzyme cholesterol desmolase, okay, or via cholesterol side cleavage. Now, action of your cholesterol desmolase to this parent molecule cholesterol is actually the rate limiting step of steroid hormone production. And this is usually expressed in all three layers of the adrenal cortex. So all three layers, the G, F, and the R, have this what we call cholesterol desmolase, or via the CYP11A1. Okay, let's proceed. Of note, ACTH, take note here, ACTH, or the adrenocorticotropic hormone, induces steroidogenesis in all three zones by stimulating this rate-limiting enzyme, the cholesterol desmolase. Now, the downstream fate of pregnenolone will depend on the specific enzymes found on within that zone. Okay, so depending on the enzyme which acts upon your pregnenolone, okay, it will produce a particular hormone, the downstream of events. Now, let's start first with the first layer, glomerulosa. Okay, now since the glomerulosa does not have a 17 alpha hydroxylase enzyme, pregnenolone can only be converted into progesterone via the action of the enzyme 3-beta hydroxysteroid dehydrogenase, beta hydroxylase, which catalyzes conversion of your progesterone to 11-deoxycorticosterone, and then your 11-beta hydroxylase, which catalyzes conversion to corticosterone. Finally, your aldosterone synthase, which is present only in the glomerulosa and in turn is regulated by angiotensin II, converts your corticosterone into aldosterone. Now, of note, aldosterone, corticosterone, and deoxycorticosterone all have mineralocorticoid activity, with aldosterone being the predominant mineralocorticoid in man. So we will be discussing the actions of your aldosterone, no, in the next succeeding slides. But for now, I want you to note that these three, deoxycorticosterone, corticosterone, and aldosterone, all have mineralocorticoid activity, with aldosterone having the most predominant mineralocorticoid activity in man. Now, in the fasciculata, the zona fasciculata, 17 alpha hydroxylase converts your pregnenolone, and progesterone, okay, converts your pregnenolone and progesterone, which were synthesized in the glomerulosa, into 17 hydroxy pregnenolone and 17 hydroxy progesterone, respectively. 3-beta dehydrogenase converts your 17 hydroxy pregnenolone into 17 hydroxy progesterone. 21 beta hydroxylase converts 17 hydroxy progesterone to 11 deoxycortisol, and 11 beta hydroxylase converts 11 deoxycortisol to cortisol. Cortisol in turn is the predominant glucocorticoid. In the reticularis, there's 17-hydroxypregnenolone, this molecule, and 17-hydroxyprogesterone can be converted into DHEA or dehydroepiandrosterone and androstenedione by your 1720 ligase, or this is also known as 17 alpha hydroxylase. Okay, could be also 17 alpha hydroxylase. Although DHEA is predominantly made, some of it can be converted into androstenedione and by the action of your 3-beta hydroxysteroid dehydrogenase in the reticularis. And this in turn, the androstenedione is converted into testosterone and your estradiol, which is an estrogen. Now of the molecules that I've shown in the figure in the previous slide, we have this what we call 21 carbon steroids, which are the steroid hormones composed of 21 carbons. We also have the 19 carbon steroids and the 18 carbon steroids. Now, the 21 carbon steroids includes progesterone, deoxycorticosterone, aldosterone, and cortisol, wherein progesterone is the precursor for the others in the 21 carbon series. Now, hydroxylation at carbon 21 leads to the production of deoxycorticosterone, okay? At the carbon 21 leads to the production of deoxycorticosterone, and this deoxycorticosterone has mineralocorticoid activity together with your corticosterone and aldosterone, but it does not have any glucocorticoid activity. Hydroxylation at C17, okay, when progesterone is acted upon by 17 alpha hydroxylase at this 17th carbon, it produces 17 hydroxyprogesterone, which is converted into cortisol. Cortisol in turn has glucocorticoid activity. Now, at the 19 carbon series, these 19 carbon steroids have androgenic activity and are precursors to the estrogen. If the steroid has been previously hydroxylated at C17, the C21 side chain can be cleaved to yield the 19 carbon steroids, namely your dehydroepiandrosterone or androstenedione in the adrenal cortex. So here, your steroid are previously hydroxylated at carbon, okay, at carbon 17. And then by the action of your ligase, we yield, okay, a 19 carbon steroids we call the DHEA and androstenedione, which are precursors for your sex hormones. Now, the adrenal androgens have a ketone group at C17 and are excreted as 17 ketosteroids in the urine, and in the testes, androstenedione is converted to testosterone. Then we have the 18 carbon steroids, which includes those hormones with estrogenic activity. Now, oxidation of the A ring. So by oxidation, we mean we aromatize, okay, the precursor molecule. We produce estrogens. This aromatization, this oxidation of the A ring happens in the ovaries and placenta, but not in the adrenal cortex or testes. Okay, so it is this molecule which undergoes aromatization to produce your estrogen, and this only occurs in the ovary and in the placenta, but not in the testes or the adrenal cortex. Now, I've mentioned a while ago that these hormones have roles in the body, and secretion of these hormones are regulated by the different parts of the endocrine system. Now, let's start first with the regulation of the glucocorticoid secretion. So this oscillates with a 24-hour periodicity or circadian rhythm. And for those who sleep at night, cortisol levels are highest just before waking up, 8 a.m., and lowest in the evening, 12 midnight. So I want you to look at the figure on the right, okay, which shows how your glucocorticoid secretion is regulated. Now, remember, we have this what we call the hypothalamic control of these hormones, no? Via the action of your corticotropin releasing hormones or CRH. So your CRH containing neurons are located in the paraventricular nuclei of the hypothalamus. When these neurons are stimulated, CRH, okay, CRH is released into the hypothalamic hypophyseal portal blood and is delivered into the anterior pituitary. CRH binds to receptors in the corticotropes found in the anterior pituitary gland and directs them to synthesize POMC, or proopiomelanocortin, which is a precursor molecule for the production of your ACTH. Now, once your anterior pituitary produces now ACTH, okay, the ACTH, the second messenger for your CRH is a CAMP, and then this ACTH in turn increases now steroid hormone synthesis in all zones of the adrenal cortex. And again, recall what particular enzyme in the series it acts upon, okay? So it stimulates the cholesterol desmolase, you can still remember, thus increasing the conversion of cholesterol to pregnenolone. ACTH also upregulates, okay? So ACTH also upregulates its own receptor so that the sensitivity of the adrenal cortex to ACTH is increased. And chronically increased levels of ACTH causes hypertrophy of the adrenal cortex. Now, supposing you have sustained production of your steroid, particularly your glucocorticoid, which is cortisol in this case, what happens? So you need to control that production because you have enough already. So we have this what we call now negative feedback control of your cortisol. So your cortisol in turn, if you have adequate production, no? When ACTH is produced, triggering your adrenal cortex, particularly the cholesterol desmolase, produce more cortisol. When you have enough cortisol now, we activate the negative feedback control. And cortisol inhibits the secretion of your CRH from the hypothalamus. So cortisol will serve to inhibit production of more CRH, okay, from the hypothalamus, and the secretion of your ACTH from the anterior pituitary. When cortisol levels are chronically elevated, the secretion of CRH and ACTH is inhibited by this what we call, as I have mentioned, the negative feedback. So next is aldosterone secretion regulation. So this is under the tonic control by ACTH, but is separately regulated by the renin-angiotensin system and by serum potassium. Let's discuss first RAAS, no, the renin-angiotensin system. Now, a decrease in blood volume causes a decreased renal perfusion pressure, which in turn increases renin secretion. If you can still recall, your renin is an enzyme which catalyzes the conversion of angiotensinogen to angiotensin 1. Angiotensin 1 in turn is converted to angiotensin 2 in the lungs by another enzyme we call ACE, or angiotensin converting enzyme. Your angiotensin 2 acts on the zona glomerulosa of the adrenal cortex to increase the conversion of your corticosterone to aldosterone. Aldosterone in turn increases renal sodium reabsorption, thereby restoring extracellular fluid volume and blood volume to normal. Now remember, where sodium goes, water follows. And so if there is increased sodium reabsorption, there is also increased water reabsorption, which eventually returns the blood volume into normal. And when blood volume returns into normal, this basically causes from a decrease arterial pressure, this increases it towards the normal. As to regulation of aldosterone secretion by in hyperkalemia, okay? So remember, your hyperkalemia increases aldosterone secretion. Aldosterone increases renal potassium secretion, meaning when in cases wherein we have an increased levels of your potassium in the bloodstream, the blood circulation, the action of your aldosterone is to cause increased secretion of your potassium into the urine, okay? Restoring serum potassium levels to normal. Glucocorticoids has many actions or roles in the body. So overall, your glucocorticoids are essential for the response to stress, okay? And what are these responses? So it stimulates gluconeogenesis. So it increases gluconeogenesis by the following mechanisms. So glucocorticoids increase protein catabolism in the muscles and decrease protein synthesis, thereby providing more amino acids to the liver for gluconeogenesis. So in other words, it increases the level of your glucose for energy production. Your glucocorticoids decrease glucose utilization and insulin sensitivity of adipose tissue. So remember, the action of your insulin is to actually uptake glucose, cause cellular uptake of glucose. So your glucocorticoids decreases insulin activity, causing a decrease in glucose utilization, okay, by the body, by the cells. It also increased lipolysis, which provides more glycerol to the liver for gluconeogenesis. So again, one of its role is to produce glucose via increased protein catabolism, decreased glucose utilization, and increased lipolysis. Another action of your glucocorticoids is that it has this anti-inflammatory effect. Now, your glucocorticoids induce the synthesis of lipocortin, which is an inhibitor of phospholipase. So, lipocortin inhibits phospholipase A2. Your phospholipase A2 is the enzyme that liberates arachidonate from membrane phospholipids, providing the precursor for prostaglandin and leukotriene synthesis. And because prostaglandins and leukotrienes are involved in that inflammatory response, your glucocorticoids have anti-inflammatory effects or properties by inhibiting the formation of the precursor molecule arachidonates, okay, by its direct action on the inhibition of your phospholipase A2. Your glucocorticoids also inhibit the production of interleukin-2, thus inhibiting the proliferation of your T lymphocytes. So remember, your T lymphocytes has also a role in the inflammation process. And so by inhibiting the T lymphocyte proliferation via inhibiting your interleukin-2, which causes proliferation of your T lymphocytes, it has a role in anti-inflammatory. Now, your glucocorticoids also inhibit the release of histamine and serotonin from mast cells and platelets. So remember, your histamine are released by the mast cell. Your serotonin is released by the platelets. These molecules also have a role in the inflammatory process. And so your glucocorticoid serves to inhibit the release of these molecules. So your glucocorticoids causes suppression. No, it's one of its side effects is to cause suppression of your immune system. So your corticoid, as I have mentioned, inhibits the production of your interleukin-2. An inhibition of your interleukin-2, remember interleukin-2 has a role in the proliferation of your T lymphocytes. So your glucocorticoids inhibits production of interleukin-2, which in turn inhibits proliferation of your T lymphocytes. Remember, these T lymphocytes, including the interleukin-2, both have a critical role for cellular immunity. Okay? And so, inhibition of these T lymphocytes causes suppression of the immune system. Now, a role, no? There are times when we need to suppress the immune system, particularly during transplantation. So a pharmacologic application of the suppression of your immune system is that these glucocorticoids are used to prevent rejection of transplanted organs. Okay? So another role of your glucocorticoid is to maintain vascular responsiveness to catecholamines. So what are your catecholamines? Your epinephrine and norepinephrine. So cortisol, no, a glucocorticoid, upregulates alpha-1 receptors on the arterioles, increasing their sensitivity to the vasoconstrictor effects of norepinephrine. Thus, with cortisol excess, arterial pressure increases, and with cortisol deficiency, arterial pressure decreases. So your mineralocorticoids, particularly aldosterone, also have many roles in the body. So it increases renal sodium reabsorption via the action on the principal cells of the late distal tubule and collecting ducts. It also increases renal potassium secretion via its action on the principal cells on the late distal tubule and collecting ducts. And it also increases renal hydrogen secretion via its action on the alpha intercalated cells of the late distal tubule and collecting ducts. So let's discuss now the different disorders related to the adrenal cortex. So the next two slides will show you a table summarizing, tabulating the different features and recommended treatment for these disorders related to the adrenal cortex. So let's start with what we call adrenocortical insufficiency, okay? Or primary adrenocortical insufficiency, also known as Addison's disease. So this is commonly caused by autoimmune destruction of the adrenal cortex and causes acute adrenal crisis. Okay? Autoimmune destruction of the adrenal cortex. And when you destroy the adrenal cortex, the cells in the adrenal cortex, you actually have decreased production of the hormones produced by these cells in the adrenal cortex. So remember, there is destruction of the adrenal cortex, autoimmune destruction of the adrenal cortex. And so this disorder is characterized by a decrease in the three, okay? Decrease glucocorticoid, decrease androgen, and decrease mineralocorticoid. And so via the feedback mechanism, if you have decreased levels of this hormone, your hypothalamus, your pituitary gland acts upon, okay, by secretion of another hormones to upregulate production of your glucocorticoid, your androgen, and mineralocorticoid. And so in Addison's disease, you have an increased ACTH levels. So remember, in Addison's disease, you have destruction of your of your adrenal cortex, and so it leads to decreased production of glucocorticoid, androgen, and mineralocorticoid, and so eventually resulting in low cortisol levels. Okay, so these low cortisol levels via the feedback mechanism, low cortisol would stimulate your ACTH. Okay, ACTH secretion by the anterior pituitary gland via the negative feedback mechanism. And remember, because of this, your cortisol, which is a glucocorticoid, has a role as a function in glucose production, such that a cortisol deficiency in Addison's disease would result to hypoglycemia. And this hypoglycemia would eventually lead to anorexia, weakness, nausea, and vomiting. Okay? Now, another clinical feature of your Addison's disease is this what we call hyperpigmentation. Okay? So hyperpigmentation. So remember, in Addison's disease, you have low levels of your cortisol. And these low levels of your cortisol will stimulate the anterior pituitary gland to produce your ACTH. Now, remember, your ACTH contains the MSH fragment. Okay? The MSH fragment now, once produced, okay, in large amount, this causes hyperpigmentation. So your Addison's disease also causes decreased pubic and axillary hair in women. Why? Why decreased pubic and axillary hair in women? Remember, there is a destruction of your adrenal cortex such that it also produces a decrease in the level of your androgens, okay? Because your androgens are basically synthesized in the adrenal cortex. So a deficiency of these androgens would actually lead to a decreased pubic and axillary hair in women. Then remember also that in Addison's disease, there is, because of the autoimmune destruction of the adrenal cortex, this also results in decreased production of your mineralocorticoid. Decreased mineralocorticoid. And so this decreased mineralocorticoid, again, what's the action of your mineralocorticoid? It increases sodium reabsorption, it increases potassium secretion, and it also increases hydrogen secretion. And so, since you have decreased mineralocorticoid level, this would result to hypotension. Okay? Because remember, your mineralocorticoid increases sodium reabsorption, thus in turn increases water reabsorption. And if you have a deficiency of this hormone, this would actually not cause any sodium reabsorption, and so would not cause also water reabsorption, thus decreasing the blood volume, resulting to hypotension. And then your mineralocorticoid also, as I have mentioned, has a role in potassium secretion. And decreased levels of your mineralocorticoid would not cause any potassium to be secreted into the urine. And so your potassium would be retained in the blood circulation, leading to hyperkalemia. And then another role of your mineralocorticoid is to actually cause, as I have mentioned, hydrogen secretion. Remember, your hydrogen has a role in the metabolic role in maintaining the acid-base balance status, such that in Addison's disease, a decreased secretion of your hydrogen would cause accumulation of this hydrogen in the circulation, leading to metabolic acidosis. Okay? So all of these are caused by hypotension, hyperkalemia, metabolic acidosis. This is caused by your aldosterone deficiency. Now, another, not shown here, not shown in the table, another adrenocortical insufficiency, so is your secondary adrenocortical insufficiency. We have primary, which is also known as Addison's disease. Not shown here is what we call a adrenocortical insufficiency disorder. We call secondary. Okay, secondary adrenocortical insufficiency, which is caused by a deficiency of ACTH. So in the first place, there is nothing wrong with your adrenal cortex. What is wrong is that there is a deficiency in the production of your ACTH. And remember, your ACTH acts upon your cholesterol desmolase, which is responsible for the production of pregnenolone. Your pregnenolone is the molecule now which is converted into mineralocorticoid, glucocorticoid, and androgen depending on the enzyme that acts upon it. So a deficiency, okay, a deficiency of this ACTH would lead to this what we call secondary adrenocortical insufficiency. So this does not exhibit hyperpigmentation in contrast to your primary. Okay? Remember, your primary is characterized by hyperpigmentation because of the increased production of your ACTH. Your ACTH has the MSH fragment which causes the hyperpigmentation. Remember, in secondary adrenocortical insufficiency, okay, there is a deficiency of your ACTH. And so this deficiency it does not exhibit the hyperpigmentation which is characteristic of your Addison's disease. Now to compare also, your secondary adrenocortical insufficiency does not exhibit volume contraction or hypotension, hyperkalemia, or metabolic acidosis because, again, there's nothing wrong with your adrenal cortex in this secondary AI or adrenocortical insufficiency. And so this would also mean that your aldosterone levels are normal, unlike in the primary AI. And other symptoms otherwise are similar to those of Addison's disease. Okay, other symptoms. Now, another pathophysiology characteristic of your adrenal cortex is when there is adrenocortical excess. Okay, so a good example of that disorder, characterized by adrenocortical excess, is your Cushing syndrome. So this is most commonly caused by the administration of pharmacologic doses of glucocorticoids. And this is also caused by primary hyperplasia of adrenal glands. Okay? So causes of your Cushing syndrome, primary hyperplasia of the adrenal glands, or the administration of pharmacologic doses of glucocorticoids. Take note, we also have the term Cushing's disease. So it's different from Cushing syndrome because when you say of Cushing disease, this is usually caused by overproduction of your ACTH. Okay? Overproduction of your ACTH, which is not characteristic of your Cushing syndrome. So your Cushing syndrome is characterized by, so again, it's an excess, adrenocortical excess. So this is characterized by increased cortisol and androgen levels. So increased cortisol would mean increased glucose production, eventually leading to hyperglycemia. Increased androgen levels. These androgens are actually responsible for the virilization and menstrual disorders in women. In Cushing syndrome, remember, you have excess cortisol, diba? Leading to hyperglycemia. The excess cortisol, if you are listening, you can still remember via the negative feedback mechanism. The increased cortisol would actually send a feedback to your anterior pituitary gland, to stop releasing ACTH. Therefore, in Cushing syndrome, due to an increase in cortisol, you have a decreased ACTH. So if caused by primary adrenal hyperplasia or pharmacologic doses of glucocorticoids, you have to expect a decrease in ACTH. But in Cushing's disease, remember, in Cushing's disease, there is an overproduction of your ACTH. And so to contrast, in Cushing syndrome, you have low ACTH. In Cushing's disease, you have increased ACTH. Now, there is increased protein catabolism and muscle wasting. Okay, so it increases protein catabolism and muscle wasting, and then these proteins are converted into glucose via gluconeogenesis. Again, that's the action of your cortisol, causing hyperglycemia. So this also causes central obesity, characterized by round face, supraclavicular fat, will follow hot or wound healing, and this also causes hypertension. Hypertension, okay? So remember, um, in Cushing syndrome, you have elevated levels of your cortisol and also aldosterone. So this eventually leads to hypertension and also osteoporosis. Okay? So osteoporosis, with osteoporosis, elevated cortisol levels causes increased bone destruction or bone resorption, leading to osteoporosis. So your ketoconazole is an inhibitor of steroid hormone synthesis and can be used to treat your Cushing disease. Cushing disease, no? Cushing syndrome. Then also metyrapone. So I've mentioned this already, no? Your Cushing's disease. Then we have your hyperaldosteronism, also known as your Con syndrome. Then we have your hyperaldosteronism, also known as your Con syndrome. So this is caused by an aldosterone secreting tumor and is characterized by hypertension. Okay, so remember, in Con syndrome, there is increased production of aldosterone because a tumor has been secreting a lot, no, in increased levels of aldosterone. So one of the role of your aldosterone is to actually cause sodium reabsorption, and increased sodium reabsorption leads to increased water. Okay, increased water reabsorption also, thus also increasing ECF volume and blood volume, eventually leading to hypertension. Another role of your aldosterone, again, as I've mentioned, it increases potassium secretion into the urine. And so an excess of your aldosterone would eventually lead to an excess, more potassium to be secreted into the urine, thus eventually leading to hypokalemia. And then another role of your aldosterone is to increase secretion of your hydrogen into the urine. Okay? And so an excess level of your aldosterone, you will lose more hydrogen into the urine, secreted into the urine, eventually leading to alkalosis. Okay? So there is also decreased renin secretion. Remember, one of the factor causing an increased renin secretion is if there is decreased arterial volume. But in Con syndrome, you have increased ECF volume, thus in turn increasing aldosterone because of the aldosterone level, increased aldosterone level. No? So this would actually give a feedback mechanism causing a decrease in renin synthesis. Then we have, this is usually treated by a spironolactone, which is a diuretic, no? An aldosterone antagonist. And of course, we address the problem by removing the tumor. Then we have your 21 beta hydroxylase deficiency, which is the most common biochemical abnormality of the steroidogenic pathway. So it belongs to a group of disorders characterized by adrenogenital syndrome and is characterized by a decreased cortisol and aldosterone levels. So remember, your 21 beta hydroxylase is responsible for the conversion of molecules to produce aldosterone and cortisol. So a deficiency of this enzyme would lead to decreased cortisol or glucocorticoids and decreased mineralocorticoid or aldosterone, because the enzyme block prevents the production of 11-deoxycorticosterone and 11-deoxycortisol. So you review the picture I've shown in the first few slides, which are actually the precursors for cortisol and aldosterone production. So in turn, a deficiency in your beta hydroxylase would result in increased accumulation of your 17-hydroxyprogesterone and progesterone levels. And this eventually also increase ACTH level. Why increase ACTH? Because remember, you have decreased cortisol production, and your cortisol, actually decreased cortisol level would give feedback mechanism to your anterior pituitary gland, telling it to release more ACTH for it to produce more glucocorticoids. Okay, so a decrease glucocorticoid and a decrease mineral corticoid and decrease adrenal androgens would actually eventually result to hyperplasia of the zona fasciculata and zona reticularis because of the increase or high levels of your ACTH. And then I mentioned that your 21B hydroxylase deficiency is characterized by increased adrenal androgens. Okay, so this is because I mentioned that in 21 hydroxylase deficiency, there is an accumulation of your 17-hydroxyprogesterone. And accumulation of 17-hydroxyprogesterone would lead to production of more adrenal androgens, thus causing increased levels of your urinary 17-ketosteroids. Going back here. Okay, so there is a deficiency in the 21 beta hydroxylase. 21 beta hydroxylase. So a deficiency of your 21 beta hydroxylase would mean that progesterone is not converted into deoxycorticosterone producing aldosterone. So what basically happens is that your progesterone is converted to 17 hydroxyprogesterone, but is not converted to deoxycortisol because you have a deficiency in 21 beta hydroxylase. So you have more of the 17 hydroxyprogesterone, which is converted to an androgen. Okay, so you have an excess or increased androgen in 21 beta hydroxylase deficiency. So I hope you're getting the point here. So an increased level of these androgens would result in virilization in women, and since these are sex hormones, so you have increased production of these precursor of your sex hormones. So this causes early acceleration of linear growth and early appearance of pubic and axillary hair. Okay, so this in turn also suppresses gonadal function of both men and women. So early appearance of pubic and axillary hair, early acceleration of your linear growth. Then we have 17-alpha hydroxylase deficiency. So your 17-alpha hydroxylase deficiency is characterized by a decrease in adrenal androgen and a decrease in glucocorticoid. So going back to this diagram, so 17-alpha hydroxylase deficiency would lead to decreased androgen and decreased glucocorticoid. Because remember, your 17-alpha hydroxylase acts upon pregnenolone, which is converted into your androgens. And your 17-alpha hydroxylase may act upon your progesterone, which in turn gives us molecules which are converted into glucocorticoid. And so a deficiency of this enzyme, a block in this enzyme, deficiency, would actually lead to decreased androgen, decreased glucocorticoid, and increase mineralocorticoid activity, because you do not have enzymes which will convert these two molecules into glucocorticoid and androgen. And so all of these molecules are converted into mineralocorticoid. So in 17-alpha hydroxylase deficiency, you have increased mineralocorticoid levels, such that if you have decreased androgen secretion production because of a deficiency of this, a block, no? So you have a lack of pubic and axillary hair because you have decreased production of androgens. And this also leads to, what's the effect? What's the role of your cortisol? It increases glucose levels. So a deficiency of your 17-alpha hydroxylase would not cause conversion of your progesterone to 17-hydroxyprogesterone, eventually leading to production of cortisol. So a block would mean there's no cortisol production leading to hypoglycemia. Okay? So you get the point now, no? So you need to just master this figure, the synthesis, the steps for you to note, no, the different abnormalities. So again, I've mentioned there is increased mineralocorticoid levels because these precursors are converted all to mineralocorticoid. So what do we expect? What are the other clinical features? So So increased aldosterone would mean we have also metabolic alkalosis. Why? Why metabolic alkalosis? Remember, the action of your aldosterone is to increase hydrogen secretion. And then an excess level now, okay, because you have excess level of your aldosterone, you'll have a lot of your hydrogen secreted into the urine, depleting your hydrogen stores in the blood, causing eventually alkalosis, so metabolic alkalosis. What else? It also causes hypokalemia, because again, I have been saying this over and over again, your aldosterone has a role in it, such that it increases potassium secretion into urine. And excess of your aldosterone mineralocorticoid activity would mean more potassium be excreted into the urine, and so eventually leading to decreased potassium, depleting potassium stores in the blood, leading to hypokalemia. And of course, what's the other role? It increases sodium reabsorption. And sodium reabsorption increases, so increased sodium reabsorption would increase in water reabsorption, thus eventually causing an increased extracellular fluid volume, eventually leading to hypertension. Question: ACTH levels, is it increase or decrease in 17-alpha hydroxylase deficiency? Increase, decrease? Should be. What's the major contributory factor to an ACTH release? Your cortisol levels. Since you have low cortisols via feedback mechanism, okay, via feedback mechanism, this would stimulate your anterior pituitary gland to release more ACTH. Thus, an increased ACTH in 17-alpha hydroxylase deficiency. So let's discuss briefly the different laboratory methods, no, and how we usually detect disorders, no, these disorders. So we have this what we call hypercortisolism or Cushing syndrome, which I have mentioned a while ago is caused primarily by excessive production of cortisol and ACTH. So it is also, aside from increased ACTH, this is also caused by the increased pharmacologic use of or overuse of corticosteroids. So a screening test would be a 24-hour urinary free cortisol test, which if you have Cushing syndrome, you'll have an increased levels, particularly more than 120 micrograms per day. Then we also have this what we call overnight dexamethasone suppression test. So your overnight dexamethasone suppression test is the most widely used screening test for your Cushing syndrome. So how do we do it? So a 1 milligram of dexamethasone is given to the patient. No? So the patient takes it orally between 11 p.m. and 12 midnight. Why? Because remember, your cortisol production is low at these times. Okay? So after the patient has taken orally 1 milligram of dexamethasone, blood is collected the following day at 8 to 9 a.m. So why 8 to 9 a.m.? Because this is a particular time of the day where you have increased levels of your cortisol. And aside from blood, no, a urine may be collected, may be tested for its metabolite, no? Urine metabolite. Remember your 17-hydroxycorticosteroid. 17-hydroxycorticosteroid. So your 17-hydroxycorticosteroid is measured by this what we call Porter-Silber method. So I will not discuss or on that because you have a separate laboratory briefing, no, on these methods. And then another glucocorticoid metabolite is your 17 ketogenic steroids, which is detected by Zimmermann method. So what I want you to note that a method which detects your 17-hydroxycorticosteroid is your Porter-Silber method, which produces a positive yellow color. A method which detects the 17 ketogenic steroids is your Zimmermann method or reaction, which gives us a reddish purple positive color. Now to note, 17-hydroxycorticosteroid and 17 ketogenic steroids are the degradation products of your glucocorticoid. So meaning degradation products, they are basically found in the urine. So urine is the specimen. No? So another test is this in in normal no in normal patient without Cushing syndrome during overnight dexamethasone suppression test would have a cortisol value of less than 5.0 microgram per dl and a 17 hydroxycorticosteroid level of less than 4 milligrams per grams creatinine after the test. So a positive result would be a cortisol level not suppressed or a cortisol level of more than 5 microgram per dl and a 17 hydroxycorticosteroid level of more than 4 milligram per gram creatinine. So another test is your salivary cortisol test, wherein we use saliva to measure the amount of cortisol. Now, a confirmatory test for Cushing syndrome, so supposing you have a positive result, positive screening test, any of these screening tests for Cushing syndrome, you need to confirm it by these tests. So we have a low dose dexamethasone suppression test, a midnight plasma cortisol, which a positive result would be a more than 7.5 milligram, more than 7.5 microgram per dl level of your cortisol. And then we also have your CRH stimulation test. For discussion purposes, so how do we do low dose dexamethasone suppression test? So this is also the most widely used confirmatory test. So we give the patient 0.5 milligram oral dexamethasone every 6 hours for 2 days. And then we collect a 24-hour urine and serum samples. We use serum samples and urine, 24-hour urine and serum samples as specimens. So a positive result would be an elevation of your cortisol levels. Then we have also tests for your hypocortisolism. Okay, so or tests for adrenal insufficiency. Primary adrenal insufficiency and secondary adrenal insufficiency. So in the previous slides, I have already differentiated between primary and secondary. So usually the primary hypocortisolism or your primary adrenal insufficiency is due to a decrease in cortisol production because of, again, autoimmune destruction of the adrenal cortex, leading to decrease in mineralocorticoid, glucocorticoid, and androgens. So with an excess ACTH levels. So a screening test for these two is this what we call the ACTH stimulation test or the cosentropin stimulation test. Okay? So how do we do this? So we take the baseline cortisol levels. So we use blood serum sample, and then after we have taken the baseline cortisol level, we administer 250 micrograms of your cosentropin. We give it IV, and then after that, after 30 minutes, we repeat cortisol level. We collect again sample for a repeat cortisol level identification or measurement, and then after an hour, we get another sample for the final cortisol level. Okay? So how do we interpret the test? So your ACTH stimulation test or your cosentropin stimulation test differentiates secondary adrenal insufficiency, okay, from tertiary adrenal insufficiency. So cosentropin is a synthetic cortisol aldosterone stimulator. Is an aldosterone stimulator. So again, it differentiates secondary from tertiary adrenal insufficiency. So in secondary adrenal insufficiency, okay, so again, we check AM cortisol. So confirmed adrenal insufficiency would be less than 5 level. Indeterminate would be 5 to 15, and then more than 5, you need to exclude adrenal insufficiency because this would mean we have increased levels of your cortisol. So those samples with indeterminate levels, okay, determinant levels, we proceed with ausyntropin stimulation test or ACTH stimulation test. Wherein after we have given an oral dose of your not an oral, no, an IV dose of your cosintropin. We keep on measuring your cortisol level such that we are expected, no, we are expected if we give cosintropin IV, no, a cortisol level of less than 18 would confirm a decreased level, no, would confirm the presence of adrenal insufficiency. So you would then differentiate primary from secondary. So you measure ACTH such that a high ACTH level is characteristic of your primary. Why? Remember, there is an autoimmune destruction of the adrenal cortex in primary hypocortisolism or primary adrenal insufficiency. This autoimmune destruction of adrenal cortex would lead to decreased mineralocorticoid, decreased glucocorticoid, decreased androgen. Decreased glucocorticoid would mean decreased cortisol, and decreased cortisol would actually, via the negative feedback mechanism, would stimulate your anterior pituitary gland to release more ACTH, such that you should know in primary AI or adrenal insufficiency, you expect to have high ACTH levels. But for secondary, which is caused by a decreased production of your ACTH, the defect is in the pituitary gland, so you expect to have low ACTH. So another alternative test is this, what we call metyrapone. Okay, metyrapone test. So your metyrapone test measures the ability of the pituitary gland to respond to declining levels of circulating cortisol, thereby secrete ACTH. So let's discuss these tests. No? What happens to this in this test? How do we interpret the test? So the metyrapone test is a stimulation test to assess the hypothalamic pituitary adrenal axis. So in essence, it is a practical dynamic test to assess adrenocorticotropic hormone research. So these tests can be done randomly. You don't have any special patient preparation instructions, meaning this can be done at any time of the day. So unlike your cortisol testing, wherein you need to collect sample at 11 to 12 and then 8 to 9, etc. because of its diurnal or circadian rhythm production, secretion. So a lavender top tube is placed on an ice, no, a pre-chilled EDTA tube is required since when you transfer samples from collecting samples to the lab, it must be frozen. So plasma would need to be separated also from the cellular component as the blood is drawn. So separate plasma directly, no, after centrifugation, because the cells, no, this would actually prolong contact of the plasma with the cellular component would cause a false results. Okay? Because your cells may trigger production of that hormone. So the analytes to be evaluated in your metyrapone test are ACTH, serum cortisol, and 11-deoxycortisol. So how do we do it? So metyrapone test, what's the principle? No? So metyrapone inhibits the action of 11-beta hydroxylase. So remember, your 11-beta hydroxylase is an enzyme which converts your 11-deoxycortisol, if you can still remember that the figure I've shown, okay, the synthesis figure. Your 11-beta hydroxylase converts your 11-hydroxy-deoxycortisol to cortisol. So your metyrapone inhibits the action of your 11-beta hydroxylase. So a significant decline in serum cortisol releases a negative feedback. So if you have blocked this activity of the beta hydroxylase, 11-beta hydroxylase, you would have decreased level of cortisol because your 11-deoxycortisol would not be converted to cortisol. So this decreased cortisol level would release a negative feedback to the pituitary gland and hypothalamus, negative feedback to the pituitary gland and hypothalamus, thus causing, what's that feedback again? This would cause increased synthesis and secretion of your ACTH and corticotropin releasing hormone by the anterior pituitary gland and hypothalamus respectively. So in healthy individual, during methyropone tests, if you have blocked the activity of your 11-beta hydroxylase, you are expected to see an elevated levels of your deoxycortisol. Why elevated? Because this would be accumulated because it is not converted into cortisol. And then you'll have a decreased cortisol level, and decreased cortisol level would stimulate your pituitary gland and your hypothalamus to produce more ACTH. Hypothalamus would produce increased CRH, which in turn acts upon anterior pituitary gland to produce more ACTH. Now, in patients with primary AI, remember there is an autoimmune destruction of your adrenal cortex. And so autoimmune destruction of your adrenal cortex would mean you don't have any of these enzymes. Okay? So in the first place, no molecule is converted into cortisol because you don't have these enzymes, and this precursor molecule is not synthesized also because your adrenal cortex is destroyed. So you'll have a decreased deoxycortisol level. Decreased deoxycortisol level would mean a decreased cortisol level and increased ACTH. In secondary AI, wherein the defect is in the organ which produces your ACTH, okay? So this still is characterized by a decreased 11-deoxycortisol, and then also a decrease in cortisol level, no? Because you have decreased deoxycortisol, eventually leading to an increased ACTH level. So to note, okay, your methyropone test will not actually differentiate your primary and your secondary AI. What would differentiate it is the cosintropin test. So your methyropone test is just diagnostic nor confirmatory that you have primary and secondary AI. And then this is followed by cosintropin or ACTH stimulation test. Okay. So another laboratory method is for the detection of your congenital adrenal hyperplasia. So I have mentioned before in my lecture in urinary screening of metabolic disorders, no? Congenital adrenal hyperplasia, which is detected in newborn screening tests. So it results from a deficiency of enzymes such as your 21-hydroxylase, your 11-beta hydroxylase, and 3B hydroxy, this should be hydroxy, steroid dehydrogenase isomerase, which are necessary for the synthesis of cortisol. So your CAH, so your CAH or congenital adrenal hyperplasia would result to decreased plasma cortisol, increased ACTH levels, and increased levels of your androgens. So for the diagnosis of hirsutism and virilization, a measurement of total testosterone and DHEA 5 would be of great help. So a definitive test, okay, for your CAH is this what we call 17 OHP measurement in the amniotic fluid and genotyping cells from chorionic villus sampling. So again, I've mentioned this is characterized by a deficiency of these enzymes, particularly 21-hydroxylase deficiency is the most common form of congenital adrenal hyperplasia. So in 21, remember, I mentioned this already, no? In 21-hydroxylase deficiency, you have elevated levels of 17-alpha-hydroxyprogesterone, which are indicative of that disorder. So this leads to hirsutism in women, and ACTH stimulation and 17-alpha-hydroxyprogesterone tests are used for testing. Then your 11-beta hydroxylase is the second most common form of your congenital adrenal hyperplasia. which we note an increased level of deoxycortisol. And this is also associated with virilization and hypertension. So I have discussed this already, no, in the tables that I have shown in the previous slides. And then your 3B, hydroxy, steroid dehydrogenase isomerase deficiency results to an elevated ratio of your 17 alpha hydroxypregnenolone to 17 alpha hydroxyprogesterone and an increased ratio of DHEA to androstenedione. So I've mentioned this also in the synthesis, okay, synthesis figure that I have shown. So I have a separate lecture for the catecholamines which are produced by in the adrenal medulla in my next in the endocrinology lecture series. So your exam would cover only hormones, no? The discussion on adrenal cortex. Thank you very much for listening. Have a good day.